Good morning. I'd like to thank Dr. Sanjay, Dr. Anant, and Dr. Jayesh for allowing me to participate in this meeting. My job is to tell when to do the anterior or the posterior approach. There's no controversy when you have a single two-level involvement, but when there is more than three or more is involved, one has preferences to do anterior and posterior. And how do we decide? Like a patient who comes like this with multiple level involvement, which is better? Whether anterior only is better or posterior only is better, or doing it combined. And if we in a setup like this, setup in our country, we have to decide the minimal surgery with the minimal cost with the best outcome. Now, people who believe in anterior approach, for this case, they do multiple level discectomy and fusion. The advantage of doing an anterior approach is that the early initial recovery is better, as the kyphosis case can be better corrected. People who believe in posterior, they do either a laminectomy, laminoplasty, or laminectomy with lateral mass fusion whenever there is a loss of kyphosis. But then which is better, the anterior or the posterior? This paper came in 2009, and then they analyzed, and what they concluded that the correction of kyphotic alignment was better in the anterior group, and there is short-term recovery was better in the anterior, but at the end of 2 years, there was no significant difference, as the loss of the correction is again, correction doesn't persist. This paper came in 2013, compared with a meta-analysis of anterior versus posterior approach for multiple level cervical spondylotic myelopathy. And this paper came in 2014. Again, it's a meta-analysis. Now, what they concluded was that whenever there is the number of segment involved was less than 3, the anterior was superior than posterior. But when it was 3 or more, then the results were similar. But there was one significant difference, that the complication rate was higher in the anterior approach. Like the complications reported was the reoperation rate was to the extent of 16% in the anterior, and this was primarily due to hardware failure or graft malposition or pseudoarthrosis or adjacent level disease, 12%. So as compared to posterior approach, the reoperation rate was only 0.9%. So if you compare this with the meta-analysis, it appears that posterior approach or laminoplasty is better. But what are the causes of implant failure in the anterior approach? As the primary cause is because osteoporosis is higher in the anterior part and the bodies of the cervical than the pedicle in lateral mass. This paper was published in 2011 when they analyzed the density. The highest density in the elderly was in the pedicle, followed by the lamina, followed by the lateral mass, and the least density was in the anterior part of the body, and hence the implant failure led pseudoarthritis. Everything was higher in the anterior. So if one believes this concept, probably posterior is better for less of implant failure rate. So keeping in mind this, probably posterior, as in age, old elderly patient is osteoporotic, posterior is better. But then one also has to keep in mind the spine alignment is the key to recovery of the patient. Now, if one does posterior, one has to decide which one to do, laminoplasty, laminectomy, or laminectomy plus lateral mass fusion. Now, is there a significant difference between these three, whether lateral mass fusion is better? Or what does the literature say? The literature, when they compared with or without fusion, they found that there was no significant difference between only laminectomy or lateral mass fusion, because at the end of 12 months, the functional outcome was similar. So if you look at this, neither the anterior or the posterior approach is better, because neither anterior and posterior approach, all the time we concentrate only on decompressing the narrow spinal canal, but we never concentrated on getting back the normal alignment or physiological alignment of the spine. Normally in spinal myelopathy, we find 3 types of cervical spine, like a sigmoid shaped spine, reverse sigmoid spine or a kyphotic spine. And because of this, the spinal cord is stretched out. And this stretching of the spinal cord causes worsening or is the cause of the deficit. And while doing surgery, not only doing a physical decompression of the canal, one also has to restore the normal alignment so that the spinal cord is not stretched out. Like in sigmoid shape, the spinal cord also is stretched because of the deformed spine, or a kyphotic spine also, the spinal cord is stretched. Now, what happens whenever the spinal cord is stretched because of deformity? People have done evoked potential animal study. When the spinal cord is stretched, the mm, the evoked potential level fall because the blood flow reduces, and especially it is more at C4 and C5 level. That is why most of the time you find myelomalacia at C4, 5 level. So a good surgery should not only stress on decompressing the spinal canal, but also restore the normal length of the spinal cord by achieving the normal alignment of the spinal column. Now, sagittal normal alignment can be achieved by achieving the sagittal balance of the spine. Now, either a hyperkyphotic or a hyperlordotic spine is because of associated changes in the lumbar spine. So one has to take care of the whole spine rather than just taking care of the cervical spine to have a good outcome. That this is the reason most of our patients have both neck pain together. They don't come stand alone. So how do you achieve cervical spinal alignment? To achieve the spinal alignment, whenever there is a hyperlordotic spine, the T1 vertebra is angulated more inferiorly. Hence, the superior surface of the T1, if one draws an angle from the horizontal, it becomes large. That's called the T1 slope angle. Whereas normally the T1 slope angle should be less than 20. If it's more, then it's not physiological. That is why they do not improve. So during surgery, one has to achieve this normal slope angle, and that can be achieved by using T1 also as a fixation point during fixation, so that one achieves the normal lordosis, and hence the stretching of the spinal cord is reduced. So this is what is the T1 slope angle, which is drawn from the upper surface of the T1, apical plate of the T1 as a horizontal plane, and the upper surface of the T1, that is T1 slope angle. And in either a kyphotic or a hyperlordotic spine, the T1 slope angle increases. And after surgery, one has to achieve a normal T1 slope angle. And if one achieves normal slope angle, then the recovery becomes better. So this is what is the normal spine with a normal T1 slope angle. And when you have a hyperkyphosis, the T1 slope angle increases as it was shown in the previous picture also. But after surgery, one can see here, we do a post-op CT scan to see that we have achieved normal the slope angle, T1 slope angle after surgery. If you have achieved this, then these are the patients who will have a better long-term good recovery. To analyze this, we studied the cases which we had done in 2015 and 16 when we were not including T1 as a fixation point, and 17 and 18 where we started using the T1 to achieve the sagittal balance. We had 28 patients in this group and 38 patients in this group. We analyzed the pain score, the modified Japanese score, and the sagittal balance parameter by CT scan in these two groups of patients. These are the parameters which are seen: the T1 slope angle, the neck tilt angle, the calves angle, as well as the SVA. What we found is in group 2, when the T1 was included, that there is the pain score was significantly less when we had corrected the sagittal balance by including the T1. Similarly, the neurological functional outcome, which is statistically significant in the group 2 where sagittal balance was collected, they had a better motor recovery and sensory recovery, and this was statistically significant. And achieving the T1 slope angle was also better when we included T1 rather than not included T1, and which was again statistically significant. This I've already explained. So in conclusion, the functional results of the outcome not only depends on physical decompression of the canal, but achieving the sagittal balance. And this paper, which is published in 2019, they also stress that good outcome can be achieved by correcting the sagittal balance and not only the enlarging the spinal canal. In conclusion, cervicothoracic junction, including the T1, helps in correction of sagittal balance, and hence it improves neurological outcome. It prevents junctional instability, and using alternative levels of fixation is cost-effective and safe. And sagittal balance correction is equally important in recovery as like doing a physical decompression of the canal. So to conclude, if you have a less than 3 level disease, it's anterior approach, but if it's 3 or more, it's the posterior approach. And if you posterior approach, the preferred techniques would be laminectomy with lateral mass plating with sagittal balance correction, gives a better results. And this has been accepted for publication by Neurology India. It's in the press. Thank you for your attention.